A very good morning to everybody. Now that we know all the treatment modalities available and how to manage a patient of keratoconus, I'll be presenting a few interesting cases. So this was a 43-year-old female who was a known case of keratoconus in both eyes. She came with complaints of blurring of vision for 1 week. Her anterior segment examination was within normal limits. Her intraocular pressure measured by non-contact tonometer was 10 millimeters in the right eye and 9 millimeters in the left eye. Her fundus examination was within normal limits. A very peculiar complaint that the patient had was she noticed jumping of letters while reading. As she was a known case of keratoconus, we performed pentacam, and on pentacam she was found to have grade 1 keratoconus by Amsler-Krumich classification, and it was non-progressive. The scans were stable as compared to her earlier scans. This was one more patient who was a 28-year-old female, known case of bilateral keratoconus, on follow-up since 3 years and her scans were stable. Postpartum 2 weeks she came for a routine checkup and there was minimal progression of keratoconus. Her refraction, her best corrected visual acuity was 612 in the right eye and 69 in the left eye. 13 days later, she came with complaints of increased blurring of vision and difficulty in reading cell phone display. On examination with her previous glasses, her vision had dropped by 2 lines in both the eyes. So what was the cause for these complaints in both the patients? Most of the times, these are the questions that we face. Why would a keratoconus patient develop acute near vision problem? Why would vision suddenly decrease with the same refraction? Many a times, because of the past history of a particular disease, we tend to go by the same protocol and forget to look at the entire picture. So we need to look beyond the obvious. In the first patient who had complaints of jumping of letters, this was what was found on the perimetry. She had an inferior quadrantenopia, and on CT scan, she was found to have an occipital lobe infarct. The second patient had a bitemporal hemianopia, and on MRI, what was seen was there was increased hyperintense signals seen in the pituitary area along with fluid levels and hemorrhage. So the patient had pituitary apoplexy. So many a times we just tend to look at what the past history is and we tend to just brush apart all the other things. So we need to give a careful attention to the overall picture of the patient.
Sometimes